Okay, right. So it's going to be contraception. So what is this image? Loop. It's a loop. Okay, Lippi's loop. Okay. So methods of contraception, we are classifying it as a totally 8. Okay, natural method, barrier contraception, IUCDs, intrauterine contraceptive device, and then hormonal contraceptives. Okay. In hormonal contraceptives, there is another type, that is postcoital contraception. Okay. And then immunological methods, and then male contraception, and finally sterilization for both male as well as female. Okay. These are the major classifications. Okay. Right. So first is going to be abstinence. That is natural methods. Abstinence. Okay, abstinence is the most effective one. And then it is going to be temperature, Billings method, calendar method, in coitus interruptus. See, all these are done during the period of ovulation, to understand the period of ovulation. Like for example, temperature method is where the temperature is going to be a little high during the ovulation period. Billings method is the change in the mucus, cervix mucus during the period of ovulation. So identifying that will tell you the time of ovulation. Okay. Calendar method is you find a definitive period which is unsafe. Okay. Comparing the cycle length. Okay. And coitus interruptus is the interrupting during ejaculation. Okay. That is coitus interruptus. So all these are the natural methods. Coming on to the barrier methods. Barrier methods can be either for male or female. Okay. That is called, this barrier methods can be additionally supplemented with spermicidal agents also. Okay. So what are the different male condom you know of? That is the regular latex made out of latex, and it is the regular condom. Whereas female condoms, female barrier methods are the following, like diaphragm or Dutch cap, cervical cap, Dumas cap, okay, and then female condom and vaginal sponge. So all these, what they do is they act as barriers so that they do not allow the sperms to enter into the genital tract. Understood? By either covering the cervical os or by absorbing using the vaginal sponge. Okay. So condom, you have to understand what are the advantages and disadvantages. See, advantages apart from contraception is going to be protection against sexually transmitted diseases. Okay. Yes, so protection against sexually transmitted diseases, and that is one of the important ones. But what is the disadvantages? Disadvantages, it is actually what to say, coital dependent. Coital dependent means for each and every coitus you have to use a condom. Okay, and also it can create allergic reaction, and the failure rate is very high. 15 that is failure rate is 15. Okay, IUCD is going to be the next, that is intrauterine contraceptive device. Okay, intrauterine contraceptive device is going to create a mechanical and biochemical and histological change in the endometrium. Okay, so it is a device. It is going to occupy the endometrial cavity, so thus creating biochemical and histological changes, and also it prevents implantation. Okay, and there will be an inflammatory response that will be happening inside the endometrium, so there will be poor implantation once again, and also it causes increased tubal motility. Understood? So different types of IUCD. Once again, classification is non-medicated and medicated. And third generation. Non-medicated is just a simple Lippi's loop or any plastic, T-shaped plastic device which is kept inside the uterus. Okay, it is a mechanical one. Whereas second is medicated. Medicated is by using copper T. Okay, that is copper. Copper containing IUCD is the second generation. Third generation would be hormone containing IUCD. Okay. So how first generation is just plain mechanical device, second is copper containing, third is going to be hormone containing. Fourth generation is going to be frameless IUD. Frameless IUD means there is no structure at all. So it is just going to be, it is going to have we will see what is frameless IUD. So these are the different types of IUCDs, copper Ts. Okay. So this is multi-load. That is, this one is multi-load, and this is going to be progesterone. That is, this is a steroid reservoir. Okay. Yes. So how will you insert copper T? By no touch technique. No touch technique is the insertion method. That is, you should never touch the copper T. Whatever you are keeping inside the uterus or inside the endometrial cavity should never be handled by hand. Okay, it should be always sterile. So you should not touch the copper T. You just have to insert the plunger, push the copper T inside through the plunger, and then remove it off. Okay, yes. So the frameless IUD we were speaking, that is gyne fix. This gyne fix is nothing but it is going to be a string of beads that is going to hang from the uterus. And next is Assure device. Assure device is something which is going to be kept inside the tubes, fallopian tubes. Okay, so that there is block of the fallopian tubes and it will not allow the implantation. Ovulation will happen, implantation will not happen. Okay. So what are the advantages, disadvantages you know of? Advantages is it is very safe and it is a long-term reversible contraception. It is long-term contraception, but you can reverse the contraception. Okay. But what are the disadvantages is it can cause infection, it can cause bleeding issues. Okay. And also it can cause ectopic also. So when and all you should not use is this disadvantages. You can, that is the condition where there is infection. Okay. Like pelvic inflammation or there is pregnancy or heavy menstrual bleeding. So in all these conditions, you should never put IUCD inside. Understood? The complications can be classified as three: immediate, early, and late. Okay. Immediate means immediately there can be a cramp, that is pain. Pain can be the first thing. Early complication can be infection or it can be bleeding. Okay. Or it can be expulsion. Okay. But whereas late is going to be once again PID, it can be ectopic pregnancy. Okay. Perforation and period menstrual irregularities. Okay. So next coming on to the that is coming on to hormonal contraceptives. So hormonal contraceptives, they can be given through various routes. Like it can be oral, it can be parenteral, or it can be device. This device is what's third generation IUCD. Correct? Okay. So hormonal contraceptives are oral. Oral is we all know that is combined preparation, OCPs, oral contraceptive pills. Okay. And then it is going to be single preparation, that is only progesterone only pills, POPs, or estrogen only pill. This is oral. Whereas parenteral, it can be either injectable or implant. Injectable means you give it every month or every 3 months. Implants means you just implant it beneath the skin so that it constantly releases the hormone. Okay. And the third degree IUCD, there is third generation. This is generation actually. Third generation IUCD is it can be levonorgestrel ring. Okay. And apart from that, you can also go for vaginal ring, insert it into the vagina, and it can also be a transdermal patch. Okay, transdermal patch. Understood? So in OCPs we have got different generations of OCPs based on the generations of the progesterone. Okay, so very simple progesterone is norethindrone. That will, if that is added to the OCP, it is first generation. Then it is levonorgestrel. This is the most famous one, where levonorgestrel is a very commonly used progesterone that is added along with ethinyl estradiol. If you see, ethinyl estradiol is a constant in all the OCPs. Only the progesterone, depending on the generation of the progesterone, we classify the OCP in different generations. Okay, the current one is going to be drospirenone. The current one is drospirenone. Okay, and Dynogest. That is the recent one that has come. Dynogest. Okay. Yes. So Dynogest and drospirenone DDs, two Ds are the current newer generations that is available. I mean newer drugs that is available in OCPs. So what is the mechanism of action? First and foremost thing is going to be inhibition of ovulation. That is what we need. The patient should not ovulate. Okay, but still bleed. Understood? And also, since it's a hormone, it is going to have its effect on ovary as well as on the endometrium. So on the endometrium, it is going to create a sad endometrial hypoplasia. So it doesn't cause endometrial thickening itself. Okay, it doesn't cause endometrial thickening at all. That is why this method of action is what is used for AUB. You understand, we were seeing OCP, OCP, OCP everywhere. Why? Because it doesn't create any thickening of the endometrium. So that is why it is used as a treatment in AUB. Correct. Understood? And also it interferes with tubal motility and alters tubal transport. Okay. What are the non-contraceptive benefits of COCs? See, menstrual irregularities, menstrual related problems. You can use in AUB, you can use in fibroid, you can use in endometriosis, you can use in dysmenorrhea. In all the conditions that we saw in the last session, OCP was one of the medical management, correct? So the same thing is going to be used here. Okay. And the next thing is protection. What is it protecting us from? It is protecting us from ovarian cancer, endometrial cancer, and PID. Understood? Why ovarian cancer and endometrial cancer is actually being it is protective against these two, because both ovarian cancer as well as endometrial cancer, what is the hormone that is responsible? Estrogen. Okay, so since OCP has got both estrogen and progesterone, it is going to have a protective effect on these two conditions. Understood? And what are the other adverse effects you know of? Adverse effects is going to be thromboembolic disorders, hypertension, and then other cancers, liver, hepatic adenoma. All these are going to be adverse effects. So the next slide will tell you what is going to be the absolute contraindication of COCs. Absolute contraindication is any circulatory disorder, that is thromboembolic disorder, anywhere. Okay, it is contraindicated. Next is liver disease, contraindicated. Okay. Other than that, if there is going to be any estrogen dependent neoplasm also is going to be like breast CA, that is contraindicated, and pregnancy. Okay. But you have to remember that thromboembolic disorders, liver disorder, and breast CA are the most important places where you should never use OCP. Understood? Apart from that, liver disorder, even jaundice, gallbladder disease also come into play, and even hypertension also. This is all its category 2. And you see here hyperlipidemia. Hyperlipidemia is also there. That is liver lipid. Okay. All these conditions you should never use OCPs. Yes. This okay. So this is hormonal. Okay, that is hormone. That is what we said. We were studying about OCPs. That is oral. Okay. Now coming on to the inserts. Inserts are going to be two things. That is parenteral. Parenteral are either it is going to be injections, okay, or it is going to be implants. So this implant is what is called as norplant. Okay, subcutaneous, that is a subdermal implant, subdermal insertion of the implants. Okay, now what is the advantage of implant? Once again, it is long acting. Okay, and it is coital independent. Understood. And it can be used by anyone, lactating mothers and women. See, one thing you have to understand is progesterone is always safe in everywhere. That is why all the treatment plan starts with progesterone. Okay, because progesterone is a very simple drug which is going to counteract estrogen. Okay, and it is not very harmful also. So progesterone will be the first drug. So wherever, if you do not know whether to use OCP or not, no, you just plainly put progesterone. It is going to play the important role. Okay. So even in lactating mothers and older women, see, progesterone can be used. But the problem is you can have breakthrough bleeding, because progesterone is very notorious for bringing about bleeding on and off. Okay. So breakthrough bleeding can happen. And however, local infection can also be a problem, and it can be very expensive also. Which one? Implants. Okay. And what are the other devices that you know of? The devices is, one thing is IUCD, third generation IUCD. Second is going to be rings and patches. Correct? This is what we saw. So rings is vaginal ring, which is called as Nuva ring. Hormone patches, Ortho Evra. And Synchroman is another drug, which is otherwise ormiloxifin or Chaya. Chaya is our government prepared ormiloxifin tablet. Chaya. Okay. Ormiloxifin, I think you will remember ormiloxifin we already studied in AUB and fibroid. Okay, it is a selective estrogen receptor modulator, SERM. Okay. Next comes emergency contraception. Emergency contraception, these are the various drugs that can be used. Okay. Once again, progesterone. Progesterone is the first, and next comes OCPs. Okay. levonorgestrel split dose, that is 0.752 doses taken at 12 hours apart within 72 hours. If you give, then it is going to be pakka. Otherwise, you go for OCP. Okay. And then what? Single dose also is available. See, progesterone has got single dose also. 1.5 mg single dose. Okay. So, progesterone is the first. Second is going to be OCP. Third, we have ulipristal. Ulipristal is one very efficient drug. 30 mg single dose. It can be given even up to 5 days. Okay. Ulipristal. Understood? It's a very effective drug. And then what are the other drugs you see here? Mifepristone. See, mifepristone is another agent that can be given. Okay, and IUD. IUD is IUCD. IUCD can also be put. It can be given even up to 1 week also. IUCD. Antiprogesterone. That is why it will interfere with implantation and it will not allow pregnancy to happen. Okay, we were using mifepristone in abortions and medical termination. But here the mifepristone is given well before implantation itself so that implantation does not happen. There is no progesterone effect at all. Understood? So, yes. So, see, these are the drugs that is actually given. Hmm? Now, coming on to the permanent method. So, what is the permanent method? That is for sterilization. We have got male sterilization as well as female sterilization. So, male sterilization is vasectomy. Okay. It is an outpatient procedure, very simple. It is a minor procedure and libido is not affected. And the important thing that you should know of is it does not create, that is, it does not produce what? Sterility immediately. It does not produce sterility. It does not produce sterility immediately. Okay. So that means you have to confirm the absence of sperms. You have to confirm the absence of sperms by doing semen analysis and then only the sterility will be achieved. You understand? Yes. And what are the other complications that you know of? So here, once again, any complication of surgery, it's going to be hit. That is hemorrhage, infection, trauma. Okay. All these three. அதுலயே அப்படியே வந்து அந்த காம்ப்ளிகேஷன் ஆஃப் வெசக்டமி எழுதிருங்க. ஓகேவா? Done. Coming on to female tubal sterilization. So, female tubal sterilization, once again, it is going to be a permanent solution for all the multiparous ladies who do not wish for any further pregnancy. Okay. Various methods are there. First, laparotomy, that is open method, or mini laparotomy, where the incision is very small, and then vaginal laparoscopy and hysteroscopy. Now, currently, most common performed is going to be mini lap or it is laparoscopy, and that too, especially laparoscopy is getting more. It is becoming higher now. Various methods are there: Magdalena, Uchida, Pomeroy, Irving, fimbrectomy. The most commonly done, or the most that is the only standardized one that is being done today is Pomeroy's. Okay, where you tie both the tubes and then you cut it off. Understood? And then in laparoscopy, what happens is you have got clips or you have got fallope rings. Okay. So what happens is laparoscopy is very advantageous because it has got a very smaller incision. There is no big scars or anything, and it is highly reversible. Okay. But the disadvantage, once again, you can say it is going to be hit. It also you can say, and also the equipment is very expensive. You need a learning curve to do this. Yes. So what is this? Very good. What is this? What is the answer for this? Which is the most effective postcoital? Levonorgestrel is the most simpler and the best, simpler one. What I said is the best. D, norethistron. Norethistron is a progesterone. Levonorgestrel is also a progesterone. Ulipristal, I said delay. Ulipristal is going to be effective for 5 days. It is one of the best drugs, 30 mg OD, single dose. Okay. Where did we see ulipristal previously? Fibroid. Okay. Right. Okay. Once again, comes to this clinic 5 days later. What is the type of postcoital contraception? 5 days ஆயிடுச்சு. What is the thing that you can use? I said Ah, இது IUCD, intrauterine device. You put something inside so that it will never allow pregnancy. You understand? Only two things. On 5 days, it is going to be ulipristal or it is going to be IUCD. Okay? IUCD has got much more longer effect, even up to 1 week also. Okay? Yes? Which of the following is an absolute contraindication of IUCD? Superb. Non-scalpel vasectomy. What is correct? I mean, what is not correct? Very good. Sterility, there is never sterility immediately after vasectomy. Okay? IUCD can be safely inserted in the postpartum female. How many, what is it? How many hours later? Okay. Post plus, that is postpartum IUCD. Till how many days? 48 hours. 48 hours. Okay. 32-year-old woman presents with intermenstrual bleeding after insertion of IUCD. What will you do? Very good. Reassure and observe. Okay, because bleeding is the immediate complication that will come. Maybe it might settle. Okay. According to MEC, in which of the following conditions combined oral contraceptive pill can be used? So, what is MEC? MEC is medical eligibility criteria wheel. Okay. So, it is like a wheel. Okay. There are various conditions in the outer ring, if you see. Okay. In the inner rings, each ring represent um, one type of contraception. Like the first ring is combined oral, that is OCP. Second is POP. Third is also POP but injection. Then it is implant. Then levonorgestrel IUCD and copper IUCD. So considering, for example, if you see PID, if you take this concept, this PID will be that is each ring will correspondingly give you the what to say, whether we can use or not use, like, because if it is given, if it is termed 1, it means you can use any left right, there is no contraindication at all. Whether if it is going to be given 4, then you should not use. That is why, for example, in PID, okay, these two are given 4. That means what is those 4? What is those two are IUCDs. See, PID we never use IUCD, correct? Okay. That is how, this is what is called as medical eligibility criteria B. Now, according to MEC, in which of the following conditions combined oral contraceptive can be safely used? Will HIV do anything with OCP? Ah, okay, understood. Right. Which is an absolute contraindication for the use of contraceptive implants? Okay. Undiagnosed genital bleeding. Okay. Any implant, anything, never implant if it is going to have an unexplained infertility. I mean, unexplained bleeding. Mm. Okay, good. Okay. Very good. PID. Infection. Obviously, you should not give within 8 hours. Best. A. Very good. Levonorgestrel, single dose tablet, 1.5. Irregular menstruation. What is the contraceptive of choice? The already irregular menstruation. OC pills. OC pills is correct at least. Correct? Okay. Contraindicated in DVT. Yes, oral contraceptive pills. Because oral contraceptive, I said thromboembolic disorders is a contraception, liver disorder is a contraception, breast CA is a contraindication, and pregnancy lactation is a pregnancy is a contraindication, pregnancy lactation. So here OCP, because DVT is a thromboembolic disorder. Okay, contraceptive contraindicated in postpartum. இதுதான் இது புரியலையா? போஸ்ட்மார்ட்டம்ல கொடுக்க கூடாத கான்ட்ரசெப்ஷன் எது? ஓசிபி. ஓகே, ரைட். இப்பதானே பார்த்தோம். ஏன்? பிகாஸ் ஓசிபி has got higher that is it has got much favorable, it is very favorable for creating thrombosis. Okay, already antenatal and postnatal period is a highly coagulable state. I said la procoagulable state. So thromboembolism is much very common. So never give OCP during that time. Okay, post coitus after 96 hours. Best contraception. IUCD. Patient who was using contraception, copper T, presents with 20 weeks pregnancy. IUCD is placed at the fundus. Tail is visible at os. She wants to continue the pregnancy. What will you do? Remove எப்படி பண்றது? ஃபண்டஸ்ல இருக்கு. Leave IUCD in situ and continue. Okay? Okay. 28-year-old lady who does not want to conceive after abortion. What is the preferred mode of contraception? Yes, IUCD. Absolute contraindication of OCP or all except. No. Smoking is actually the age less than 35 years. What with the age? Any age you can give. Yeah. OCPs can lead to எந்த ஆர்கனை பத்தி நம்ம வந்து இந்த ஆர்கன் ப்ராப்ளம் இருந்தா கொடுக்கூடாதுன்னு சொல்லிட்டு இருக்கோம். லிவர், ஹெப்பாட்டிக். கரெக்டா? Which of the following is a preferred mode of contraception recommended during lactation? Hey, OCPs should not be given. IUCD. Simple. Okay. Government will do only two things during pregnancy and lactation. One is IUCD, another one is sterilization. Okay. Because those two are the safest ones. Most common complication of IUCD insertion? Yes. Mechanism of action of OCPs? அதுல என்ன ஆன்சர் அப்போ? மூணாவது ஆப்ஷன் பாருங்க. ஓவலேஷனே அவங்க கொஞ்சம் சுத்தி கொடுத்துருக்காங்க. புரியுதா? Right. Was using IUCD as a method of contraception. If he is having repeated blackouts, that means what is the likely cause? No, here ectopic pregnancy is an important thing because we already studied IUCDs is going to occupy the endometrial cavity. So the only space that the ovum will get implanted is the tube. So ectopic pregnancy is very common with IUCD. You understand? Okay. Good. Right. We'll finish it off. Huh? Huh?